of us had the wonderful opportunity to go down to Buenos Aires to Alex's meeting called the E20. And we were initiated into a very unique format for a way to give a presentation and a talk. And we enjoyed the format so much that we have asked him and Caroline Sat to bring the E20 format to the AFS. So without any further ado, I'd like to invite to the stage Alex Neoponce and Caroline Sat, and we will get started.
All right. Thank you very much, Dan. Caroline. All right. Well, good afternoon. First of all, thank you to the AFS board and our friends, because we started this new format in 2019, and we thought it was original, that we liked it, but we couldn't be more proud to being asked by AFS to bring it up here, and it's an honor to try to do the same thing with these amazing speakers, and we are going to try to do that with Caroline today. You may wonder why E20, and the story is really funny, because I was putting together the first course. My son at that time was 15. He still talked to me, and he said, "Dad, what are you doing?" And I said, "We're bringing the best experts from the world about esophagus, and we're having a meeting." And at that time, the G20 was in Argentina. And he said, "Oh, it's like the G20, but for the esophagus." And I said, "You're right, we're going to call it E20. I said, "No, you're not." "Yes, we are going to call it E20. And that's how it all started. But so one of the original parts of the format is that there's only clapping at the beginning and at the end, because it's a continuous session. And so you're going to clap very loud, all the speakers that Caroline will introduce.
Good afternoon. It's a pleasure to be here. I'm from Brazil, and it's the first time that we're bringing this format here. So thanks again for the invitation. It's a great pleasure and an honor. So this session is the post-myotomy issues and potpourri. So I'm going to present you all the presenters. So Dustin Carson, that is Assistant Professor of Medicine of Northwestern University. Mike Yushki, Vice Chair and of Clinical Affairs of Department of Surgery of North Shore University. Daniel Smith, Surgeon and Esophageal Institute of Atlanta. Virginia Little, Surgery and St. Elizabeth's Medical Center. And Barham Abu Dayet, Gastroenterology at Mayo Clinic. And Kenneth Chang, Professor of Clinical Medicine, University of California. And last but not least, Kimberly Howard, Physician Assistant at Duke University Medical Center. So let's start.
Come on up on stage, and a big clap for all of them. Okay, so if we can go to the first slide of the presentation. As I said, we brought it from Argentina. This is the Argentinian iPad, how an Argentinian iPad looks like. And we are going to start with the question. Some of you have already worked through this system in Argentina. Some of you didn't, but it's going to be fun. So to start, I will start on the front line, as we should always start, because the patient always comes to the front line, right? And, we did a myotomy on a patient, and most of the times everything goes well, but sometimes the patient comes and he says, "I was so good the first 2 weeks, and now it's not working." And he gets anxious, and it didn't work. And we know it works, we just need to get some relief. And that's how Kim gets a patient, right, in the front line. So what do you do with those patients? Do you do something before? Do you do something after the surgery to prevent that first month of inflammation period?
Yeah, so I think it's really important to note that doing the post-operative care really does begin preoperatively. So a lot of it has to do with the preoperative education, setting expectations, and really helping these patients be part of their journey. A lot of them haven't heard of achalasia before they come to our clinics. It's not a very common thing. And so doing a lot of that education is important. With respect to the postoperative inflammation, right, we don't start with a phone call saying, I have postoperative inflammation. So we start with quotes like this. And sometimes it can take a minute to stop and think. And for me, it's sort of an algorithm about, are they calling me with some kind of alarm symptom? Am I worried about a pneumothorax? Am I worried about a leak? Or if I'm not worried about one of those things, no fever, no shortness of breath, et cetera, I sort of then triage over to look at the timing and the trajectory of their dysphagia. Most of the time, we can get these patients through just with a lot of reassurance, right? I think it's also important to note here that the patients had this surgery, right, with the hopes of eating better afterward. And so when temporarily they're eating worse afterward, they're incredibly anxious. And so it's our job on the front lines to offer a lot of reassurance to these patients, and also just help them be patient and slowly advance that diet. Sometimes I feel like patients will go too quickly to the soft food diet, and so I have a pretty low threshold for taking them back to the full liquid diet if they're reporting a lot of dysphagia. Counsel on avoiding gum, straws, things like that, and then we usually get them better over the next few weeks.
Perfect. Absolutely. Thank you, Kim. But sometimes it does go wrong because some things we get, it may happen like this case where in another center, they operated a patient, 20-year-old patient, long history of dysphagia. They did a high-resolution manometry. IRP was 18. Distal esophageal peristalsis, something was not completely clear. Some signs of stasis, the pH was abnormal, LA grade B, and they decided to do a poem. They thought it was an achalasia, that it was a stasis, and they did a poem, and the patient didn't do well. So sometimes it doesn't do well because we did the wrong thing to start with. And then they did it, it came to the clinic, we scanned the patient, and it had a leiomyoma. And it was an extrinsic compression, so they did a poem on something that shouldn't have a poem. Dusty, is there a way that we can avoid these things from happening in most of the centers, not only academic centers?
Yeah, absolutely. And I think that, I think to your point here, the first starting point is really confirming the diagnosis, and particularly with this manometric pattern of EG outflow obstruction. And even here from a semantic standpoint, when we say that we're talking about the manometry pattern, I mean, the more global EG outflow obstruction could be anything that's discovered on an upper endoscopy, and that is where the first cut in the Chicago classification is in the application, and it implies that this is patients without a overt mechanical obstruction, so they've had a non-obstructive endoscopy. And in efforts for Chicago 4.0, it was really to try to make this diagnosis more specific. So incorporating a more involved protocol, 2 positions, supine and upright, IRP value should be elevated in both of those positions, but also looking for other clinical features to help support that diagnosis. But even in the end there, even with Chicago 4, we find that there's still just an inconclusiveness to that manometric pattern. And really in the end, this EG alpha obstruction is not a specific disease. And even when we confirm that there's a conclusive EG alpha obstruction, that doesn't mean it's achalasia. There's a whole differential diagnosis for even conclusive EG alpha obstructions as well as that manometric pattern. And it ranges from achalasia, a scenario and a syndrome where patients may get better from a myotomy, but other findings, other subtle mechanical obstructions, a missed stricture on endoscopy, a small hiatal hernia, opioids can cause this type of finding.
Excited.
And as well, I mean, even the manometry itself can have artifactual, kind of a false positive elevation in IRP. A lot of where Chicago 4 comes through helps root out some of that. But one of the conclusions with Chicago 4.0 was that when you have this manometric pattern, to seek additional testing, and this is where using EndoFlip and using time-bearing esophagram comes in to help confirm that. And so the task I was given was to talk about using FLIP to look at EG outflow obstruction. And first off, that comes down with, again, doing a high-quality FLIP. And with FLIP, we can see that if we apply these different objective measures of EGJ distensibility in open, the EGJ DI gleaned from the 60 ml fill volume with the 16 centimeter catheter, and then also bringing in the diameter, the greatest EGA diameter when the balloon is overinflated, when the flip is filled up to the 70 ml fill volume, that when that's normal, the DI is more than 2, there's a max EGA diameter greater than 16, it has a very high negative predictive value for having a relevant outflow obstruction. And in that scenario, actually, I have to go back for 1 sec. But in that scenario, achalasia can be very effectively ruled out. But on the other side of that, even on the right side of this slide here, you see that patients who don't have conclusive EGA outflow obstruction can sometimes have reduced EGA outflow or have reduced EGA opening on flip. And so this part needs to be interpreted really in the global clinical context with manometry, clinical presentation, really helping to try to identify this appropriate diagnosis. All right, and so when we use flip, we're talking about classifying esophageal motility, and a lot of power on the ends of the spectrum here. This first one up in the upper left, and that's the normal pattern. Repetitive antegrade contractions, normal EGA opening. When you see that pattern, the probability of having achalasia is next to 0. On the other side, reduced EGA opening and absent contractile response, that's something that goes along with achalasia and often non-spastic achalasia. But there are other abnormal patterns as well, and some of these things we've called spastic reactive features. These can be seen in achalasia, but they also can be seen in other conditions as well. So again, just bringing these factors in to identify what might be normal or a non-conclusive disorder of outflow obstruction, and what findings are going to be more supporting a relevant diagnosis and maybe even supporting achalasia. We did a study a couple years ago looking at this specific problem, looking at when there's a manometric EGA outflow obstruction and using flip to identify who had a conclusive EGA outflow obstruction and who had a conclusive achalasia-like EGA outflow obstruction, because we looked at therapeutic outcomes. And patients who had the right manometry by Chicago 4.0, who had the right flip using this obstruction with weak contractile response or spastic reactive pattern, and those patients did very well when they got achalasia-type therapies. On the other side of that, when there was normal EGA opening, patients did very well with conservative therapies. And obviously, very few people in this observational study got achalasia-type therapies, but the ones who didn't get better. There still is a middle ground here, though. There's some of these findings that can still be a little bit inconclusive. And that's where ultimately we bring these other features together. And even in this study, it was an observational study, but we didn't make these decisions based on flip alone. It was based on that whole global clinical picture. What the symptoms, what the patients presented with symptom-wise, how the endoscopy looked, getting time-bearing esophograms and using those data, using other features on manometry, the rapid drink challenge being a very important finding, and really using all of those features together to find that achalasia-type version of EGA outflow obstruction and then tailoring therapy to that group.
Yeah, thank you, Dusty. Well, it's really important to focus before we start so we don't make mistakes, right?
Absolutely, yeah. The starting point is the diagnosis.
Exactly. So, Mike, no matter how good we are, we always get there that we did a great myotomy and the patient comes back and symptoms recur, right? Mm-hmm. And we don't know why, but they recur. So this is actually one of the cases you brought up, a 58-year-old male patient. He went under a laparoscopic Heller door and again starts with dysphagia, occasional weight loss, and keep losing weight, but you're sure that myotomy was okay. Something happened, it recurred. Is it that we did an incomplete myotomy? Is it a stricture? Is it fibrosis? Is it an extrinsic compression from the fundus herniated? How can you tell?
Yeah, so I purposely left the timing of when that procedure was done out, because when it comes to dealing with a patient who's had a myotomy, whether it be surgical or endoscopic, when they come back, you know, the differential diagnosis includes a lot of the things that you just mentioned, but we do see this in about 10 to 20% of patients. But what's very important, first of all, is the history, is when was this? Was it 2 weeks ago, or was it, you know, 2 or 5 years ago? You know, obviously, if it was something more recently, I worry a little bit more about an incomplete myotomy. If it's something that, if the person had a myotomy 5 years ago and was doing great, but now is coming back with symptoms, I worry that probably not an incomplete myotomy, but maybe a side effect of the myotomy. For example, GERD would be the most common. And I think it's really important in achalasia patients in particular. If you take 100 patients who have had a myotomy and you test them for reflux, or you have, 100 patients who have reflux after a myotomy, only about 50% of those are really going to have symptoms. And so we can't really rely on symptoms in those patients. So I really think that you need to consider reflux as part of the diagnosis there, which will cause a stricture. And they'll have symptoms just like they did prior to the myotomy, very similar symptoms of dysphagia. So a detailed history is very important, and then I think you have to kind of start over. I think you need imaging. That case that Dusty showed is a very interesting one. I wonder what the esophagram looked like. Would that have picked that up? If you're not sure, a CT esophagram or just a CT of the chest with oral contrast would be helpful. And that would help you maybe pick out something that's extrinsically compressing. But I think most of the time we're going to see a similar situation like this where you have really significant reflux, and those patients usually can be just treated medically. But you need to, when you do the endoscopy, make sure you look for a poorly constructed fundoplication. It happens. A recurrent hiatal hernia. I think us as surgeons, we're very worried about closing the crura very tightly after doing a myotomy because we worry about causing dysphagia. So a lot of times we're leaving the crura relatively open, maybe more open than we would if we were doing a hiatal hernia repair. And so that can lead to a hiatal hernia later. And if you have a hiatal hernia, patients will oftentimes present similar to achalasia as well. So I think for testing, I think we do a lot of the similar things. I think an esophagram is very helpful. Endoscopy is absolutely important. Remember that these patients also have a higher risk of cancer. And so you do want to have a very low threshold to do an endoscopy. And then I think endoflip is also very important. Dusty maybe can teach us, but manometry after a fundoplication, if you've done a Heller myotomy and a door fundoplication, I don't know how helpful manometry will necessarily be in some of those cases because you might see that the IRP is still high, but it doesn't mean that they have an incomplete myotomy. So I think in those cases too, where you kind of have equivocal studies, Botox can oftentimes be helpful. If you're not sure if this is an incomplete myotomy or not, you can inject Botox, and if they have a good response to it, then you know that probably going back and repeating a myotomy will be very helpful. And you can also do other things like solid barium studies. And then I think a 96-hour pH study can be helpful, but you really need to interpret those carefully. And I guess we'll go into that later, so I won't go into it now. But you have to make sure that you're differentiating between stasis, which can, falsely, decrease your acid exposure or increase your acid exposure time.
Dusty, do you think endoflip can tell between scarring or a different mechanism? What would be your guess when you have a recurrence like that?
Yeah, I think the starting point there really is the endoscopy. And the high-quality endoscopy is such an essential part of this evaluation here, because even there, stricture, esophagitis, those are all mechanical obstructions, and they're obstructions in the context where someone has absent peristalsis, so they can be amplified in the impact of what those can have. But I think at the same time, endoflip is a great tool to then help really show what the consequence of that is, see what the impairment of LES opening and EGJ opening can be. And yeah, when you're not finding something, that is we're bringing in other tools. Sometimes this case is an interesting one, but endoscopic ultrasound, imaging, but putting that whole piece together to identify what that mechanism of dysphagia and obstruction is at that point.
But even if we may have a good diagnosis, we still need to treat that, right? We have a dysphagia and we need to treat it. And sometimes we have the feeling that pneumatic dilation may work better after a myotomy than a prior dilation for achalasia. People have sort of forgotten about dilation as a primary treatment for achalasia because the recurrence was sort of high, but that doesn't seem to be the case after. It's like you're cracking the myotomy and it stays open, right? Virginia, is the pneumatic dilation a better option after the myotomy, after a recurrent disease?
Yeah, so I'm just citing a study because I don't do pneumatic dilations. Pneumatic dilation after myotomy in this study of 8% laparoscopic Heller patients, 8% of them were considered failures, and 103 of those 120 patients underwent a median of 2 what they call complementary pneumatic dilations. I thought that was kind of a weird term, but anyway, complementary pneumatic dilations at a median of 15 months post-operatively, and they went up to 4.0 millimeters on the, or centimeters on the Rigiflex dilator. And surprisingly, no perforations or bleeding. I was a little surprised about no perforations, but they did follow up these patients for 37 months, and 3/4 of them remained asymptomatic. And they concluded that the patients should have complementary pneumatic dilations if their Eckert scores were abnormal, and but if they do not improve after 2 of these dilations, then you should consider a redo myotomy, which would be either maybe a Heller or it could be a POEM.
Oh, and I'm sure they were not complimentary, right? They were just
Yeah,
complimentary.
I know, it doesn't make any sense.
Dusty, is that your experience as well? Does the dilation work better after myotomy?
No, I mean, I think even before going to the whole 30 centimeter or 30 millimeter pneumatic dilation, I mean, when I see a patient coming in with dysphagia after a POEM or a Heller or even a pneumatic, I mean, that just with the risk of stricture there, I mean, my threshold to do a 20 millimeter dilation is exceptionally low. And sometimes you do pick up, you know, you draw some heme, get some symptom improvement from breaking up some fibrosis there, even at that lower level. And at that point, safety profile is great. But I think it does come back to the diagnosis again here too. And I mean, people are having retention, even dysphagia. It doesn't always mean that there's an EGJ obstruction at that point after treatment. And body failure and just impaired peristalsis alone can be enough to drive symptoms. But if we're confirming that there is an outflow obstruction, then pneumatic dilation is an option. I think you have a similar discussion as you do prior to therapy in achalasia, that it may not be as good or durable as a myotomy, but could be an option. There was a study that actually randomized patients who had return of dysphagia after myotomy, and they randomized the POEM versus pneumatic here. This was done from the Amsterdam group. And you have 90 patients, 45 in each arm, and they showed with a symptomatic outcome that the POEM group did do better. I think even if you look at the kind of breakdown here, though, you know, doing better, still a lot of patients in both groups with an Eckert score of 3 and 4, and you know, we keep saying an Eckert score of 3 is a good outcome. I mean, a lot of patients with an Eckert score of 3 are not all that happy. So it's, you know, yeah, there's always a couple different ways to skin a cat, and it's nice to have an additional tool that maybe has a lower reflux rate afterwards.
Ken, what are your thoughts on that? No one can drive a scope better than you do. What are your thoughts on dilating?
Yeah, I think if the patient's symptoms are relatively mild and their Eckart score is 3, 4, I think starting off with pneumatic dilation makes sense. I like to use the ESO flip to 30 as my first trial. If they have more severe symptoms and I've ruled out the other causes, then I would go to probably a POEM, so I can take a posterior approach after prior Heller.
Good. Then, if you don't have a POEM, you don't have a dilation, you have a recurrence, and you need to go the hard way, and you need to reoperate that patient. How at risk are you of messing things up?
Yeah, well, so let me give you context to my comments here. My comments are going to largely focus on answering that question, what's the risk to a myotomy, not only if you're going back to remyotomize or address a failed Heller or failed treatment of achalasia, but any foregut surgeon in the audience today is going to have to go reoperate for other reasons. Hiatal hernia, a wrap that shifts or moves. And there's not a lot in the literature on this topic. And so the context here is to first frame my comments that this is kind of all I do in my practice. So what I'm going to share today is some data, both published and personal, and then some comments about what to do to mitigate that risk. Because the answer is the myotomy is very at risk, obvious reasons. If you have to go in and reestablish the hiatus to get safe access to this area, to know what you're dealing with, and to do whatever it is you're going to do, fix a hiatal hernia, remyotomize, new myotomy, or adjust a wrap, that myotomy is going to be very at risk, obvious reasons. Go back one, because I want to say if a door has been done, it's at more risk. And this is a bit counterintuitive. Surgeons in the room, I think you might understand this. That myotomy is sitting right at the crural arch. And when it comes time to dig out the esophagus from the crura, You don't have the extra wall thickness of the esophagus to protect you from perforation. You might think, well, with a door, it's going to be a safer situation, but you're going to have to take that door off at some point. And doors in my area are largely done to mitigate perforation. So now I'm going to have a really sticky plane between that myotomy. So if there's a door involved and you have to redo anything, undo, redo, it's going to be very at risk. Data in the literature that I referred to was 58 redos that were done in prior Heller patients. Now these were for patients who had failed Heller for a variety of reasons, who were taken back to the operating room, specifically for recurrent dysphagia and, quote, failure. I'm sorry, you jumped. Oh no, single institution, no, this is the right data. 5 surgeons, we had 58 patients over a little over a decade. And in that experience, 25% of patients had some perforation at their myotomy. A quarter of the patients wound up with a perf. To characterize this, though, those were patients who were having redos to specifically address likely incomplete myotomy. So we were remyotomizing, we were needing to re-expose. Now, in my own practice over the last 10 years, I've had 28 patients who I've had to take back to the operating room who've had a prior Heller or a achalasia operation. All were taken back with dysphagia, but for a variety of reasons. About 10 of those had hiatal hernia or wrap issues. In other words, we didn't suspect we had to redo a myotomy. Instead, we were going to deal with an obvious anatomic problem of a wrap that was twisted or a hiatal hernia. More than half of these patients, though, did have what was believed to be an incomplete myotomy. And there were a couple of patients who had a poem, who had recurrent reflux, who needed to go back to the operating room. Or I shouldn't say recurrent, who had new onset reflux. So in that experience, all 28 patients were able to be completely taken down. Of those, 12 went on and had a repeat myotomy. And just for the surgeons in the room, oftentimes that's not trying to figure out what in the first myotomy went wrong. It's doing a new myotomy. It's going to a new location. It's very difficult to go into this space where all you have between you and the lumen of the esophagus is the mucosa with scar over the top of that, and figure out what part of that plane is causing the problem, or where those muscle fibers are that maybe need to be taken. Oftentimes that's rotating off of that prior myotomized area and creating a new myotomy. Some of those patients, go back, just let me finish. Some of those patients, we added the partial posterior fundoplication, a toupee essentially. Those were the 2 poem patients. And you see, in the next slide, you go ahead, you can see one of these patients had a diverticulum. Sort of blew out their myotomy and had outflow obstruction distal to that, and had to have that dealt with. So in this 28 patient experience, no perforations at takedown. And the message here is it's at risk, but you can safely reoperate on these patients and protect that myotomy and fix a hiatal hernia, undo and redo a wrap. The risk when you're redoing the myotomy is higher. That's where your greatest risk is, but you can mitigate risk of injuring that mucosa in that prior myotomized area. A couple of yeah, is this all you want from me now?
No, go ahead.
No? Okay. So the message is you can redo an operation in a prior myotomized patient. The primary risk is going to be to that myotomy if you're going to remyotomize, not with trying to do a redo. A couple of just technical points for surgeons in the room quickly. Start at the base on the left and the right. There's a cheater plane. How many surgeons in the room know what the cheater plane is? All right, cheater plane is going far enough distally on the lesser curve and getting underneath the caudate lobe, between the caudate lobe and the right crus. Unless there's mesh been used, that will always be a clean, fresh plane. Any redo, you can always find the cheater plane. It's called a cheater plane because my fellows would struggle for an hour, and I'd walk in, and in 5 minutes, I'd have the whole thing cleaned up. And my fellow said, "You're cheating." So Enter the mediastinum posteriorly, find the plane between the aorta and the back of the esophagus. It's a safe plane. It's usually not been dissected, and you can go way up with that. I will say, just a technical point, cautery at 25. At 25, you can cut scar, you can cut serosa, you will not make a hole all the way into any viscera, except maybe the mucosa at 25. Dial your cautery down, and you can use it like a Metzenbaum scissors or a very carefully managed scalpel. Work from the undersurface of both crura posteriorly around and leave that myotomized area that's stuck to the crural arch until the very, very end, and actually come at it from the bottom and the back towards you. And only do that after you know the access of the esophagus. Because the problem is the access to the esophagus, if you don't know what it is, you're going to carve right into that esophagus. Traction is critical. I get a Penrose drain around the esophagus early, and I use that to move that all over the place. So each of these tissue planes are under traction, and with a little bit of cautery at 25, that plane will just open up. Be patient, do the crural arch last, and just, don't force it. If it doesn't come, don't go there. Go someplace else, and when you come back later, where you struggled will become more evident as the anatomy sort of reveals itself.
Thank you, Dan. That was very clear, and if you need to take the risk, you need to do it well and safely. So we'll send the patients to Dan. Barham, do you think POEM is a safer alternative in these cases, that you don't need to take down anything and you can just go on the inner side and it's a clean cut, no scarring? What is your experience on that?
Absolutely. I think POEM gives a couple of clear advantages. One is you have access to the 360 circumference of the esophagus. So anterior, posterior, it's really no difference for us. And you have access to the abdominal cavity and the chest as long as you want. So the dissection could be high in the mediastinum and within the stomach as well. So this is a case of 58-year-old with hilar myotomy and orphan duplication, occurred of score of 7 at about 2 years after her hilar. I love tests that I could easily interpret, and this is a time barium swallow. You're looking at the 1 minute and you're looking at 5 minutes. 1 minute is more than 5 centimeters, and you could measure that by the vertebral body. The vertebral body is usually 2.5 centimeters, so you have a column more than 2 vertebral bodies at 1 minute, and a column of about more than 1 vertebral body at 5. So that is highly sensitive for an echolalia-like picture in this setting. So as other speakers have highlighted, these diagnoses are nuanced and they're not very straightforward. So of course you start by a good upper endoscopy to make sure you have no stricture, no esophagitis, no issues with the door, funduplication as far as twisting or herniating anteriorly. And this patient had none of that, but she had this pattern on endoflip. And that pattern showed you a couple of things. The distensibility index was about 4, but it's borderline, as you could see here. But you see that there's 2 areas of contractility pattern that is disorganized, and you could maybe argue it's a bit of a retrograde. So it's a judgment call at this point, but you see that this pressure zone is a bit longer. It's about 4 centimeters. So you need to, if you're going to do a myotomy, you need to do a longer myotomy in order to address that problem. So putting the patient clinical presentation all together, that's what we opted for. We opted for a posterior POEM approach because the patient has a door. And if you click the video, we'll highlight some of the advantages of POEM of this in this case. So if you could play the video, please.
Is it playing? I know we had a. Oh, there. I got this sign from the backup. Sorry about that.
No worries.
It was working on the speakers ready room.
Yeah, no problem. So it's the idea here is we started about 10 centimeter proximal to the G junction. We did our tunneling, and now you're seeing we're in the submucosal space. And we did full myotomy all the way to 2 centimeters within the cardia because it's a posterior approach. And we did a complete myotomy. We closed that myotomy entry, and the patient did well. in that setting. So we've highlighted this study before, so if you could go next. There has been a randomized trial, so it's when there's randomized trials, I think the evidence is pretty clear. These are patients with ECARD more than 3 after Heller with an abnormal time barium swallow. They're randomized to POEM versus pneumatic dilation. Primary outcome is ECARD less than 3 and no reintervention within 12 months after the POEM versus the pneumatic dilation. They also looked at high-resolution manometry. They repeated the time barium swallow, so looked at basal LAS pressure and IRP and the column of barium on a repeat study. And the outcomes were not subtle, actually. The success rate was double, or more than double, for the POEM versus the pneumatic dilation. And there is, if you continue to click through some of these results, there is so success rate 62% versus 26%. The basal lower esophageal sphincter pressure, IRP, and the column of barium on the time barium swallow was all in favor of the POEM compared to the pneumatic dilation. And you've had more esophagitis after the POEM compared to the pneumatic dilation, but most of the esophagitis was actually grade A or B, so it's not severe esophagitis that you've seen after this. So in sum, this trial seems to be suggesting that POEM is the superior approach. There was 1 SAE in each group, 1 perforation in POEM that was managed medically. It was a microperforation. And there was severe reflux post-pneumatic dilation that required surgical intervention to manage that. So all in all, I think we have now level 1 evidence to suggest a clear approach, though the diagnosis needs to be guarded and you need to establish a diagnosis before you embark either on a POEM or on pneumatic dilation. But putting that together, you have to be a doctor first. So somebody with ECARD 4 or 5, it's very reasonable to start with a pneumatic dilation before you jump into a POEM. Give them that benefit of the doubt, and then if you need to go to the POEM, that option is still there for you.
It's clearly. Virginia, how about the other way around? Can you do a Heller to a failed POEM, or is it tougher to do a...
Well, yeah, so this was a case report of a lap Heller and Door after a failed POEM. I have to say I don't get referred many of those, so I guess my GI colleague is doing all the POEMs now. I just gave up on that battle. But I guess he's doing a good job because I haven't seen any for a year and a half. But this was a literature review and a case report that it was a safe, basically, you can see the pictures down there, and it is a little tricky because and potentially dangerous because you can get scarring in there. But apparently from this literature review, it is safe and an effective approach. So I don't have much else to say about that, but yes, it is an option for a failed POEM.
Good.
I mean, I'd like to know how many people go back and do a redo POEM after a POEM, but anyway, that's another question.
Well, reflux is definitely one of the Achilles heels in POEM, and it's been debated all over, but it's also something that happens in achalasia, right? No matter what you do, you may expect some GERD. This is probably one of the most serious studies for randomized controlled trials in POEM versus Heller, showing equal efficacy, equal monitoring in pH, equal reflux symptoms, but more esophagitis. The interesting part is that last DEW, they presented the update of this study, and that difference started to fade away. That made sense because a little scarring on the POEM side, a little giving away on the fundoplication side. So things are starting to balance in that debate. But we know by the Pittsburgh group that body mass index, BMI, is absolutely key in the rate of reflux that we can get. So we know those patients, we have to be very careful. In patients with lesser BMI, we can be more confident in terms of doing either POEM or Heller. But I can remember who mentioned that measuring reflux in post-myotomy is not easy because of the stasis. sometimes it's not GERD. I think you, Mike, said that. So how do you define true GERD?
Well, I mean, obviously, if you have esophagitis, that makes it easy. But if you don't have any esophagitis and you're doing a pH study, you just have to make sure you interpret it well. I thought this group, I think out of India, did a very good job of showing, different patterns on a pH study. Differentiating between true stasis versus quick, pH less than 4 events that are clearly reflux. So I would urge anyone that's doing these to, refer to some of that literature and make sure that you understand it. For us, one thing that we just actually submitted this abstract, what we've noticed in our own group is because a lot of achalasia patients don't show symptoms of GERD when they have it, we have gone the last 5 years, or maybe even a little bit more, to treating all of our post-myotomy patients, whether it's a POEM or a lap Heller with fundoplication, with acid suppression for a year. And then after a year, and it could be 6 months, I know some places do that, but after a year, we know from the plastic surgery literature that wound healing is a 2-year process, actually. Now 90% of it is in that first year. So there's a lot of remodeling that's happening after we do a myotomy or a fundoplication. And so we keep everybody on acid suppression, just a very average dose, and then we bring them back and do a pH study on everybody. We urge everyone to come back, and we tell the patients, you may not sense reflux until you have a stricture, and that can cause some damage. And so we bring them back, and then if they have a negative pH study, we stop the acid suppression. When we look back at our previous way of doing things after myotomy, where we would only treat people if they came to us with complaints, we've actually really seen no need for dilations and very few interventions now in that first year, whereas in the past, we actually did have patients coming back with really severe esophagitis and strictures, and they were coming back at 6 months saying, my achalasia is back. And when we would do our workup that we've all discussed, we would actually find their achalasia, it's not an achalasia issue, it's a GERD issue. So I would highly recommend that. And I would also implore AFS, actually, to advocate for the necessity for that pH study post-op. And the reason I bring that up is most of our patients are actually getting coverage. We always get pre-approval for our Bravos. But there are some insurance companies that will not cover it because the patients are asymptomatic. And that's frustrating because now we don't know what to do with their PPI. Can we stop it or not? I don't think that's the right thing to do. And then I also would recommend that, and again, there's no guidelines anywhere that I know of that say this, but I think that achalasia patients need lifelong surveillance endoscopically as well.
Sometimes we have to admit that the door is open. And so this is one of your cases followed up at 6 months that you presented, and you see those lesions. What is your approach on that?
Yeah, so our protocol is very similar to Mike's. After POEM, we'll put everyone on PPI, single dose, follow up at 6 months, 6 weeks. And at 6 weeks, we determine whether, just based on clinical, whether we feel like we can take them off the PPI or leave them on the PPI. And then at 6 months, everyone gets a 96-hour pH study because, again, we can't trust symptoms. So this patient had minimal symptoms, but LAB esophagitis, and the acid exposure time was 6.2. So then we discussed different options, and we decided to do a TIF.
Good. So, Barham, what are your thoughts on post-POEM on GERD?
Well, similar approach as what my colleagues highlighted is you do not assume that reflux is going to be bad on everybody. That's something that we used to think. We stopped thinking that. So you just prophylactically treat it with medical treatment. So once daily PPI, you evaluate. There is going to be a cohort which they're going to have miserable reflux. They're going to be on twice daily PPI, and they're going to be symptomatic. This is the group that you intervene on, but you need to give an observation time before you get there.
All right. I think there are some slides. Yeah, there were some slides missing there. Go ahead.
So the whole GERD after POEM question, has been a real focus of ours clinically to understand it. And then, so we looked at our initial 132 consecutive POEM patients and just asked the question, how many of them needed to stay on PPIs? How many of them were refractory to PPI? So roughly 50% of them, of patients after the 96 RPH did not need anything. The other 50% needed to be on PPI. 9% or 12 we categorized as post-POEM refractory GERD, either single or double dose, or they didn't want to stay on PPIs. So amongst those 12 patients, we did TIF on all of them, and all of them responded well, if you go back. But what was interesting is that not all, so the etiology for the reason for doing the POEM actually informed whether they would need some sort of GERD rescue. So the highest GERD risk were the jackhammer spastic disorders. So I go over this with my patient at the first visit. I tell them, this is from our practice. This is your chance of needing something. And I already plant the seed that TIF may be possible down the road. So 22% chance if you've got a spastic jackhammer, 16% if you have a type 1 achalasia, 10% type 3. But for our type 2s, 1.6% needed a TIF. So they are the most GERD, have the least GERD risk. And also, our GERD is tailored. We start posterior, we rotate 90 degrees and land at the lesser curve, minimizing cutting those important gastric sling fibers. So we in our first 132 patients, none of these patients needed a laparoscopic anti-reflux rescue. Now I've done over 400 patients, and 2 patients needed a laparoscopic combined. We do CTIF. So I'm very careful also to assess these patients pre-procedure. If they have a hiatal hernia, even a small one, I'll encourage them to get a Heller fundo, therefore avoiding a 2-step procedure. Sometimes if Nin says, no, you do the POEM first, and then we'll time it stage-wise, then 2 months after POEM, then we can do a CTIF. So that's kind of our current stats. And on the next slide, I think you wanted me to present a quick case.
Before we continue talking about reflux, showed us how good you are in doing 2 things at the same time.
Okay. Yeah, so this is a 74-year-old with type 2 achalasia who also had an incidental esophageal submucosal lesion. So we did the EOS, and we thought, hey, I think that, that leiomyoma may be within the tunnel. So I tried to direct my tunnel to get to the lesion, and I was able to do a stir and then continued the tunnel and finished the myotomy. So the patient got a twofer. But then on the next slide, you'll see that the pH score. Okay, that was actually the 6-month post was that patient.
So now we go again, Barham. The TIF, CTIF, what do you do?
Yeah, so again, it's going back to the idea that do not assume that everybody's going to get problematic GERD after POEM. Give it a period of observation. So that's lesson number 1. Do not jump into these combined procedures up front. Give a clinical observation time, and usually the clinical observation times is months, not weeks, in the making. The TIF after POEM is still an open dialogue. It's an evolving field. This is the state of the literature that you're seeing in front of you. So you could click it down and we could go over it here. There's been 2 reports and all case series at this point. The first one was a bit more optimistic than the second one. The first one was from 1 center. And you could see these are pH positive, very symptomatic patients. They're on twice daily PPI. At least 3 of them had esophagitis on endoscopy. They offered them a TIF procedure at a few months after the initial POEM, and you could see percent off PPI was 100%, and the esophagitis healed on those who had it. Now, there is a more multi-center report that introduced a little bit of the nuance, if you could stay on the previous one. In the second center, which is Ken's center, is part of that report as well. 12 patients underwent TIF after POEM at an interval of about 10.4 months. The technical success was there on everybody. These are patients who are having significant symptoms despite twice daily PPI. You could see the need for PPI reduced significantly. It was not eliminated in some of them, but reduced significantly from twice daily to once daily PPI, and those who were or off PPI. And there was objective improvement on pH as measured by the Meester score and percent acid exposure time. So this is the state of the literature. It's not set in stone yet. It's case serious, seems to show promise. But the message is there's been some reports to show concomitant POEM with TIF. I do not personally recommend that. You need a period of observation to allow healing of the myotomy before you embark on another transoral procedure. And usually it's at least 6 months in my book.
And POEM F.
Well, we'll talk about that
Well,
soon, I guess.
Ken was mentioning, Inoue opened a can of worms a few years ago, and in an example of what I think it's the fact that you can doesn't mean you should. But he did it well. He did a fundoplication endoscopically, the POEM F. We don't know if the F is a fundoplication or the bad word, but at the same time, Inoue published that only 1%, and that relates, I think, to all our experience, less than 1% of the patients with POEM will end up needing a fundoplication. So does it make sense, Barham?
Well, I never say never. You have to keep an open mind. So let's play that video. That's the best telling. So you guys be the judges if it makes sense or not. I hope that video is there.
I hope the video is playing, but we're being unlucky with the...
Is it not there?
Yeah. Apparently not. It's not your day for videos.
It's not my day. Though you confirmed that they're working, so you tricked me in that.
yeah. I did see them, and it looks good actually. The POEM F looked very, very good. But
Okay.
but yeah, you can go ahead and answer if it
I
makes
will
sense
answer
or
that
not.
question. So to make sense or not make sense, I'll describe to you what's POEM F, because that's when you be the judges if it makes sense or not. So you're having a tunnel, and the tunnel to do a POEM F should be an anterior tunnel because you need to access to the anterior abdominal cavity. And once you're finishing your tunnel and you've done your myotomy, now you go anteriorly and you violate the full thickness of the cardia of the stomach, and you exit into note approach with your endoscope into the abdominal cavity. And one scope pushes on the anterior wall of the stomach endoscopically, and the other scope is looking to confirm that you're anterior on that stomach-G junction. Then what you do is you take a series of clips with an endoloop, and you start clipping the anterior wall of the stomach until you back and enter into your tunnel. And then you cinch the endoloop together, so basically you're pulling the anterior wall of the stomach to creating a door-like fundoplication within the same session. So then you close your myotomy access point as you would with a POEM, and it's quite safe actually, and it's, in their series they did not report much complications. My only hesitation is, would that endoloop and clips sufficient to hold that fundoplication together, or that's going to fall apart and the clips are going to be in the abdominal cavity at some point. So, but that's the nature of innovation, so it might not make sense to us right now, but the idea that we could do this safely is pretty remarkable to me. The technologies will improve, so we'll have better tools to do the fundoplication with down the line. Right now, I'm still on the fence, but I never say never.
We had a few worried looks out there.
I know. That's why the video was very important for that one.
Yeah. Well, we know it fades away with time, even with a Heller, right? So why would you do it to 99% of the patients that might not need it? Ken, what are your thoughts on that? Very in 10 seconds, so we move forward.
Yeah, I agree. I mean, the durability is, is of question. Because we know with a Heller fundo, the thing that's more likely to decay over time is the fundo, not the myotomy. And then again, if 99 out of 100 don't need it, you're doing it for the whole 100. So,
Virginia, sometimes, even though we try hard, the esophagus is really bad, like this female patient with idiopathic achalasia, chronic symptoms diagnosis at age 20, a lot of stasis, comparable to things like that. So sometimes we cannot avoid to take the organ out.
Right.
When do we reach that point?
Yes, well, there have been several studies evaluating this, some meta-analyses. I think you kept the slides, hopefully. But these are two foregut challenges, right? So someone comes to you with the sigmoid esophagus there, and you say, oh, we just need to remove your esophagus. Let's say it's a 40-year-old person, they've had recurrent aspiration pneumonias, but otherwise they haven't had any other interventions. The question is, what are you going to offer them? Well, these are two foregut challenges. Are you going to offer them an esophagectomy up front, or do you do an esophagectomy and then give them a complicated, dilated, redundant conduit? So this is my use of AI, Jason, wherever you are. This is the level I'm at, showing a picture. But so the megaesophagus, sigmoid esophagus, end-stage achalasia, what do? Do you just go right to an esophagectomy and then put them at risk for having to deal with a dilated redundant conduit? So we can go to the next slide. Thank you, Mike. This is your study. Some options for a megaesophagus with a sump or a neoesophagus with a sump is the per-oral plication of the esophagus or neoesophagus. And Mike's study here shows that you can use the overstitch to sort of bring in that sump and sort of straighten out the conduit or the esophagus. The other option, surgically, I mean, that's a pretty impressive axial view, CAT scan view at the bottom there. But I guess you did it. Other options for dilated conduits is you go into the right chest, you have to take down all these adhesions, and then you can staple off part of it, obviously trying to avoid the gastroepiploic. And similar for your procedure, the Pope procedure, per-oral plication of the esophagus or neoesophagus, you have to make sure you don't get the blood supply to the conduit too. And I'm not sure how you avoid that, but you just have to do it anatomically and think about where you are. So here are a couple of series, and this is actually an amazingly old study, esophagectomy for achalasia, and this is from Oranger's group over 20 years ago. And obviously, we all know Dr. Oranger does the transhiatal esophagectomy. So they reported doing esophagectomies doing a transhiatal esophagectomy for achalasia. And I don't know how many of those patients actually had really dilated, crazy sigmoid esophagi, because they report, as in this more recent study from a Chinese group, that 93 patients with achalasia who underwent the esophagectomy, they had a 93% of the patients felt better after their esophagectomy. So, but the point of this paper down there is that you have to think carefully about the indications for an esophagectomy. And here, Tom Watson did a review a few years ago, and these are some of the challenges of doing an esophagectomy on someone with a end-stage achalasia. You got a dilated esophagus, and they're chronically aspirating, and you think maybe they didn't aspirate when they're being induced for the esophagectomy, but they have chronic injury to their lung, and postoperatively, you may not even get them off the ventilator. And I have seen patients. I saw one patient who was chronically aspirating and actually didn't make it out, and it was because of the chronic aspiration. But they can have postoperative pneumonitis and respiratory failure. You also have very thick-walled esophagus with tortuous blood vessels and higher blood loss. So in Oranger series, transhiatal esophagectomy, you already have a high blood loss because you're just basically ripping the esophagus out. And we know that the transfusion rate is higher with the transhiatal esophagectomy than with other esophagectomies. But the esophagectomy options, as Dr. Watson summarized here, is you can do a long esophagectomy, which take out the whole esophagus, or a short one, or you can consider using a jejunum or a colon, or you can do an esophagojejunostomy. So there's various approaches and conduits that are available. But in my experience, you normally have to go into the chest. It's really hard to get the esophagus out, just going through the belly and up to the neck. And here is a systematic review, meta-analysis, and basically Bonavino's group concluded, and this is 6 years ago, that esophagectomy for end-stage achalasia is safe and effective, and that the complication rates weren't any different than with, in comparison to regular or esophagectomy safe for cancer. So, and similarly, more recently, a NISCA matched analysis of non-achalasia esophagectomies and esophagectomies for achalasia, they were similar. So it's a little surprising, but yeah. So when does an achalasia patient really need an esophagectomy? So these are, I would summarize, patients with severe dysphagia, weight loss, choking on food, recurrent cough, recurrent aspiration pneumonia. Now, a lot of these patients obviously have lost a lot of weight, and we know that patients who are malnourished don't do well with esophagectomies. So I'm thinking, this is all evolving, and there may be some endoscopic therapies and that we can do to combine to figure out the optimal way to manage these patients. Maybe a combination of a myotomy, a POEM, or a Heller, and then a POPE. And we'll just bridge the patients. You can put a feeding tube in, you can get them stronger, and then ultimately they may need an esophagectomy. But the crucial point is, for benign disease, you have to optimize the indications.
Good. Well, thanks, Virginia. We've been all the way from new technologies and high-end end-of-flip to a drastic esophagectomy. That's all that can get you in achalasia. But we'll go back, in the sake of time, to the front line. And Kim, in the end, they always come back to the front line. And how do you reassure these patients?
Well, so like I said at the beginning, for me, education really is my passion. And the longer I've done this, I probably spend twice as much time now with my patients preoperatively than I did over a decade ago when I started. And setting those expectations, helping them understand what we can help with, what we can't help with, right? Saying lower esophageal sphincter means nothing, right? I talk about the trap door, right? We can open the trap door, but we can't fix peristalsis. And so for that, I talk to them about a snake eating a rat on the Discovery Channel, and they can all really kind of relate to that image to understand peristalsis. So I do a lot of education about what to expect. I similar to what Ken was saying, I sort of plant those seeds early that perfect really is the enemy of good, and this is going to be a life-changing thing no matter what direction we go, whether we do POEM, whether we do Heller. And so I think that really talking to them about that it means a lot. Another big part of this is that for the most part, I'm in clinic, and we get referrals from everywhere. And so you really have to pay attention to, is this a patient that just had food impacted that went to the emergency department and they fished it out and referred it to thoracic surgery, which is what happened recently. Sometimes you get somebody from a primary care, they've ordered some studies, but the patient has not discussed any of the results with the physician. If you're really lucky, you get somebody coming from one of your trusted GI colleagues that's already gone through all of the ins and outs of achalasia. My most recent patient actually was a 19-year-old that had presented to his primary care with trouble swallowing his whole life. And then he was scoped during the emergency department, so he and his whole family came to clinic and had never heard the word achalasia. They kind of thought, they're just signing up for a simple surgery and this is going to be great. But as you can see, there was already a pretty significant amount of dilation on the swallow study that I ordered. So this was about a probably a 2-hour-long initial consult, just really talking to them about what to expect. And as you can imagine, oh, there it is. As you can imagine, a 19-year-old, male is really trying to eat a lot of pieces of pizza, right? I mean, that's kind of what they do. And I had to really kind of dial that back. So again, to reiterate, I explain what we can help with, what we can't help with, talk about how they are forever changed and really involve them in the shared decision making. It's really about that patient-centered care that we learn in school originally. And I also prep them for eventually having to meet one of the thoracic surgeons about esophagectomy. Hopefully not for several years anyway, but I definitely plant that seed ahead of time as well. This particular patient, back to sort of, fielding triage calls on the front line. When he came back on about 2 weeks post-op, he had a normal post-op course. He was immediately doing better with liquids, which were problematic preoperatively, but pasta was hanging up worse than before the surgery. And as you can imagine, he was incredibly nervous about this. It was immediately, I am worse than I was before. What happened? What did you do? And so this is what I was talking about earlier. It's a lot of reassurance and explaining that they're just sort of in that inflammation period post-operatively, and that it will get better with time. And fortunately, a couple months later, he was doing fantastic. So kind of summarize my portion of the talk with the 3 T's. It's all about teaching and being really thoughtful, and also giving things time post-operatively to help your patients.
Well, I think this is a perfect example that we are better together, and that's how E20 started, and that's how it will continue. So this is the end of the academic part of the session. If the chairman allows 5 minutes for questions, I think we are out of time. They are saying no. So let's give them a big clap to the amazing speakers, and I hope you enjoy them.
Thank you so much, Alex. And if we can have actually the faculty for the next session come on up. We have an award ceremony coming up, but one of our awardees decided he might want to get back to his hometown sometime tonight rather than late tomorrow. And so we have an award for Dr. Ronnie Foss. Ronnie, please come on up here. And so Ronnie is a professor at Case Western, probably best known as a GERD nerd, or a nerd GERD nerd, because he's really spent a lot of time looking at NERD and other sort of psychologic aspects of reflux disease along with gastromotility. We have what we call a fellow of the American Foregut Society, and the fellow is someone who has contributed not only significantly to the field of medicine in general or foregut disease, but also contributed to the society. And Ronnie has been a wonderful contributor. He's one of the associate editors for the journal. He has been very involved in research and currently is leading a NERD consensus Delphi process. So Ronnie, it's with great pleasure that we award you this wonderful translucent plaque. So, you bet. Thank you so much, Ronnie. And a pin, and also one of many little things you can post up in your office that I'm sure you have loads of those sitting in your office. So anyway, thank you so much for your participation.
Thank you very
Ronnie,
much.
thank you. Okay, well, let's actually have all 4 of our faculty come on up, my being one of them. So Felice and Muad. Yeah, come on up. That way we'll make sure you're not falling asleep or drinking a beer. Yeah, so Felice, go ahead and I'll let you introduce the session and what we're going to do.
Okay, perfect. All right, so this session, this afternoon is about a little bit of a different flavor on how the sessions are going. And so this is called 60 Minutes Lite, because it's not exactly 60 minutes, but it is going to be as critically acclaimed, and our 2 expert panelists are going to be interviewed by Dr. Bell and myself. They're going to give presentations. They have presentations that are loaded up, but I don't want the audience to be concerned if we interrupt them during their presentations. I know we've been very cordial and courteous during the other presentations, but we're taking off our gloves now, and so we might actually interrupt them at times, and that's all just part of the fun. So with that being said, our first presentation is going to be on the management of eosinophilic esophagitis. And so for those of you that get uncomfortable with people getting interrupted, let's try not to feel that way, but we'll still be friends at the end.
All right,
I didn't say your name, so
That's
I'm
okay.
so sorry.
I can introduce myself.
But we all are such friends that we know each other, but I apologize.
But thank you so much for the invitation. And before I start, I just want to say a quick congratulations to the organizers of this Congress. Really, it's been one of the best that I've been to. So the title of my presentation is The Current Management of EOE. I'd like to start with a case presentation. This is a 35-year-old man who has had solid food dysphagia for several years. He had a recent presentation to the emergency room with a food impaction, and his esophageal biopsies were consistent with EOE. Now, this patient takes omeprazole 20 milligrams twice a day for quite a while, primarily for acid reflux symptoms. His medical history is notable for eczema and allergic rhinitis. And you can see from his upper endoscopy, he has active features of EOE. He has inflammatory features, which are the edema, loss of vascularity. He has white plaques, especially in the distal third of the esophagus, that can be seen on the second image. And he has furrows throughout the length of the esophagus. He also has the beginning of fibrostenotic features with concentric rings throughout. Biopsies were taken, and he had more than 100 eosinophils in the proximal half and distal half of the esophagus.
So was this actually biopsies taken during the endoscopy with the food impaction?
That's correct. So during the food impaction, after we relieved the food impaction, we took biopsies from the distal half and proximal half.
So can you talk about that? Because I think very often we don't necessarily take that opportunity at that time. So could you just comment on that?
Absolutely. So that's a very good point, Felice. So that would be a missed opportunity if we go in, and I realize I've done this many times where I have to come in the middle of the night to do a case, and 2 in the morning, classic food impaction case, you just want to get it done and go home and rest a bit. But I think it's a missed opportunity not to take biopsies while you're there because, yes, of course it looks like EOE, but you need the biopsies to confirm the diagnosis. If you don't take the biopsies, then you have to reschedule them as an outpatient, repeat the endoscopy, and do it then. So I take them during the food impaction.
Great.
Now, the treatment algorithm has evolved over the years. This is based on the most recent guidelines published in 2020. And the way we would approach EOE is as follows. So once you have the appropriate clinical history, most likely atopic history, endoscopic features, and biopsies all together, you make the diagnosis of EOE. And one point here I want to make is, of course, we use the diagnostic threshold of 15 eosinophils. That was chosen many years ago. But just having 15 eosinophils or more does not mean EOE. So you have to have the entire picture. Now, once you have the diagnosis, you have options for treatment. You have dietary therapy, which we don't really have a lot of time to go into, and you have pharmacotherapy, of which you can do PPIs. Now, this patient happened to be on PPIs before we met, but that was an option. Or topical corticosteroids. Now, because he did not respond to PPIs, and yes, I did have the option to increase his dose to 40 milligrams twice a day, but instead, we discussed starting topical corticosteroids. Now, topical corticosteroids literally come in many different flavors. Historically, we've used the fluticasone inhaler that we give our asthmatic patients. Rather than puff inhale, in this case, puff swallow. The induction dose is typically 4 puffs in the morning, 4 puffs in the evening. There's another version of fluticasone that is currently in phase 3 trials. It's called APT-1011, and it's an oral dispersible tablet. The data looks very good so far. It'll be a singlet tablet at bedtime. Hopefully, in the next few years, this will be approved. There are also versions of budesonide that one can use. And traditionally, what we've used is we've taken the respules that we give patients who need a nebulizer, for example. We take those respules, we break them, and we put them in a small container, and we add some sort of sugar substitute, honey. There are many different vehicles for delivery into the esophagus. The point is you want to get that coating the esophagus twice a day. There is also a budesonide oral dispersible tablet that has been approved in Europe by the EMA since 2018 and has been first-line therapy in Europe and other Asian countries for many years. And now we actually have an FDA-approved version of budesonide as of summer of this year, which is a budesonide oral solution that comes in a stick pack, cherry flavored, and you got to take this again twice a day. So briefly, I just want to review the data that led to the FDA approval of this budesonide oral suspension. This was a randomized, multi-center trial in adolescents and adults with EOE. Patients were randomized to receive budesonide 2 milligrams twice a day versus placebo in a 2-to-1 ratio. Patients were treated for 12 weeks, and there were co-primary endpoints. One was histologic, one was clinical. The histologic endpoint is achieving less than 6 eosinophils, and the clinical endpoint was based on a validated dysphagia instrument known as the DSQ. A total of 318 patients were randomized. More than half were on prior EOE therapies. Nearly half had a prior history of dilation, which suggests that they have some sort of fibrostenotic features. And the vast majority were on PPI. And you can see the data. The first graph shows the histologic data, of which there was significant improvement with budesonide over placebo. And the clinical data, again, there was significant improvement over placebo, 53% versus 39% in the clinical, and 53% versus 1% in the histologic. So going back.
So how did you I mean, you showed us a whole list of steroids, right? How did you choose this?
Yes, that's a great question. So before this, we really had 2 options. We can use the inhaler, and we can use the budesonide respules mixed with whatever you want or at a compound pharmacy. The reason I chose this is because, well, now we don't have to do that because we have an FDA-approved version of budesonide. So this is us using the same drug, but it's approved for EOE.
So can you use the other ones now any longer, or would you say don't use the other ones any longer because you now have FDA-approved therapy?
You can use the other ones. I would say at this point, since we finally have an approved therapy, if cost is not an issue and approval is not an issue, which it should not be because it's approved for this condition, I would suggest starting with this. However, it's okay to use the other ones because we were using them for 20 years and they work just as well.
So I'm not really sure. I mean, I don't know, but is that exactly correct? I mean, can we definitely say that if there's ones that are now FDA approved, saying just because they worked as well, can you definitely say that you can still use them if they're FDA approved ones? I'm not really sure. I'm just asking you because I don't know the logistics of that.
Right. So I mean, if you think about it, we have budesonide mixed with a sugar substitute, and we have budesonide mixed with some proprietary liquid, but it's the same drug.
Okay.
And it's probably easier to take by cutting a stick pack versus mixing it with whatever. But it is the same drug in the end.
Okay.
And we did decide to start this patient on budesonide oral suspension twice a day. He was advised not to eat or drink for 30 minutes after taking the medication, and that's so we don't wash the medication from the walls of the esophagus. And the plan was to repeat his endoscopy at 12 weeks to assess for response to treatment. And you can see from his repeat endoscopy that while he still has some features of active EOE, there are some improvements compared to the index endoscopy. His ERF score has improved. He still has some rings. And now at the GE junction, you see that he has a stricture. The eosinophil count, which was more than 100 before we did treatment, is still above 15, but it dropped to 20 to 30. So I would say a partial response to treatment. But he is still symptomatic. So if we go back to our algorithm, the question is, where does esophageal dilation fit in this treatment algorithm? And I would say it fits everywhere. So you can do it at index, you can do it during your repeat endoscopy, you can do it at 1-year follow-up. If a patient needs a dilation because they have a stricture, you can dilate it.
So why didn't you dilate him at the index endoscopy? Because he had to have had a stricture, there was a food impaction, right?
Yes. And so when I do a case of a food impaction, depending on how long the food has been there, once you remove the food, there's usually a lot of inflammation in that area. And in that scenario, I don't dilate.
But you said to do it at the index endoscopy, so which one do you mean? Do it at the index endoscopy or not do it in index endoscopy? Which one is it?
Both. It depends on the situation.
Both.
So, and here's what I mean. If you have a food impaction and everything's very raw and inflamed, don't do it right then. Wait.
Don't do it then.
However, if you're doing an index endoscopy outside of a food impaction, or if you're doing it during a food impaction and you remove the food bolus and everything looks fine, you can go ahead and dilate right then and there.
Okay.
Now, the ASGE released guidelines on dilation in EOE back in 2022. This was based on 20 experts for EOE who got together. And here's a summary of some of the statements. Of course, we know that dilation is essential in treating EOE strictures to improve symptoms. One of the statements says that a session of endoscopic dilation should end at the appearance of mucosal disruption or if the target diameter has been achieved. And in my training, it was always taught to us the rule of threes. And I trained at Walter Reed, and we had many esophagologists who came from there, and the rule of threes were something that we always learned. But I would say in EOE, the rule of threes do not necessarily apply. And what I mean is that if you see a stricture and you dilate it, and you get mucosal disruption with that first dilator, in my opinion, you should stop there. On the flip side, if you're being very conservative and you're going up, you're going up, you're going up, and you still haven't done anything, well, keep going until you do something. So once you see mucosal disruption, that's where you should stop. Target diameter, I generally recommend working your way up to 16 millimeters. If you're starting at maybe, say, 9 at index, well, going to 16 is too aggressive right up front. So you want to work your way up to 16 depending on where you are. Different dilation techniques are acceptable. Bougie, balloon, your preference. It depends on your expertise, the center's expertise. Either one is fine. Now, going back to our treatment algorithm, and mind you, this was published in 2020. The question is, where do biologics fit in? And at this time, biologics were considered only to be available as part of a clinical trial. Of course, now we have a biologic that is approved. And the question is, well, why? We have steroids, we have diet, we have PPI. Why do we even need biologics for EOE? And the answers are that the conventional treatments don't necessarily address the underlying pathogenesis unless it's a diet trigger. The response rate to medical therapy, depending on which study, which country you look at, is 50 to 70%. The response to dietary therapy, again, this is in a setting where you have a highly motivated patient working with a dietitian at an expert center, you can probably get to 70%, but it's challenging. And then, from a practical standpoint, it's difficult for a patient, especially a young patient, to take a medication twice daily and or be on a restrictive diet. The biologic that we have approved is dupilumab, and briefly, I'm going to go over the study that led to approval of this biologic back in 2022. This was a multi-center randomized controlled trial. Patients were randomized to receive dupilumab, 300 milligrams, subcutaneous injection, weekly versus placebo, for a total of 24 weeks. The primary outcome were co-primary, clinical, and histologic, and the data was good. Using a cutoff of 6 eosinophils per high power field, 60% of patients achieved that. If we use a cutoff of 15, which I think is also acceptable, many more patients achieved that. And from a clinical standpoint, if you look at the graph, This is a weekly injection drug. We start seeing a separation by week 4 that is sustained throughout the duration of the study. And the extended active treatment arm, which goes up to 1 year, these results were sustained for 52 weeks. So going back to our case presentation, he didn't respond to PPI. He didn't respond to topical steroids. I dilated him. That helped, but that is an adjunct treatment. So I put him on dupilumab. Brought him back after a few months, and he did great. His esophagus normalized. The EREF score is 0. Biopsies showed very minimal eosinophils in the proximal and distal half of the esophagus. So the question is, who is a good candidate for a biologic? Who should we start a patient on? And I think the low-hanging fruit here is the patient who has failed everything. So, you know, if you're thinking of a step-up approach, didn't respond to anything, this is a good option. Another option, and you know, this could be debatable, but I would say if you have very severe fibrostenotic disease, you know, maybe consider a top-down approach rather than a step-up approach. And you know, again, back in the world of IBD, we used to think, no, go first, and then escalate. And then you're like, well, the disease is so severe, why don't we just start with a biologic? And that's something to consider. If a patient has difficulty with compliance of taking a medication twice a day, once a week is more practical. If a restrictive diet, which of course is an option, but if that's going to pose a long-term challenge, this is an option. And I think another easy one is because this drug is approved for multiple atopic conditions, then you can use this drug if a patient also has eczema, atopic dermatitis. You're treating them all with the same medication. So take-home points are, we have now 2 FDA-approved treatments for EOE, budesonide oral suspension and dupilumab. PPIs remain a good option, especially for mild to moderate EOE. Dilation is a very important adjunct to medical and dietary therapy. I recommend repeating an endoscopy after treatment to assess for response, and we now have 1 biologic approved and several additional biologics are in the pipeline.
Great. So, I can say go. No more time? One more question? One more question? Okay, great. Here, come sit down, my friend. So, so this was a great presentation. I loved it.
Thank you.
You spent all of this time with this young person. Endoscopy, start this, start that, start this, start that. He came in with a food impaction. Why did you not just give him a biologic at the beginning? I mean, I totally understand, you know, individuals who come in with dysphagia, they don't need an emergent endoscopy, but the expense of what you did with him, and I don't just mean endoscopies, because when we talk about expense, we always think facility fees and anesthesia costs and whatnot. Lifetime. I mean, lifetime of expense, and he kept on failing his therapies. So I'm just wondering, why would you not do top down versus step up, especially in a young person who's presenting with an urgent type of situation requiring an emergent endoscopy?
So years ago, the treatment algorithm perhaps was simpler in a sense in that, you know, start with the PPI fails, go next, and then in 2020, you know, a different approach was taken, and that is, no, you don't have to do that. Here are all your options. Here are the pros and cons of each option, of which a biologic is one of the options. I could have, of course, there is the possible hiccup of coverage if a patient has not been on a topical steroid. That is a possible issue, but let's assume that's not an issue. And I mentioned who was a good candidate. I would say someone with severe fibrostenotic disease. I wouldn't categorize him in that, you know, category. I would say maybe he was moderate disease. So I think it would be acceptable to put him on a biologic and also acceptable to put him on a topical steroid.
Okay, great. Well, thank you so much for your presentation. I appreciate your insights on the case.
There you go.
Well, John needs no introduction. John doesn't like standing at the podium. He actually doesn't even like standing on the stage. But, you know, we often shoot ourselves in the foot by saying that parasulfonylureas fail, repairs fail 50% of the time. And that's an objective measure if we were to look at PPI normalization on 20 milligrams a day. Normalization of pH, it would not be 100%, it'd be about 60%. So there's a little difference in things, but the question is, given that objective data, are we making any progress? Are we doing any better now than we were when laparoscopy started in 1991, whatever?
Well, it is a fantastic question, Reg, and I was super excited when I got this topic, when Reg asked me to talk about this. And the reason I was mainly excited is because I'm old. I didn't need to do a literature search. I've lived this. I've lived the laparoscopic paraesophageal era. And if they could show my slides, that would be helpful. And so, again, I wasn't going to do a literature review. What I was going to do and what my plan was really was just to look back on my career, where I started and where I am now. And here's where I started. I was a young, energetic surgeon ready to conquer the hiatal hernia world. Fast forward to where I am today, and a lot of things have changed, but a lot of things haven't changed. I mean, yeah, I'm older, I'm taller, my hair's not quite as blonde, but some things are exactly the same as they were. I still drink Coors beer, I still have the tattoo. Then I went back and started to look at videos of things I had tried over the years to try to improve the outcome of laparoscopic paraesophageal hernia repair. And at one point, Trip Buckley tried to convince me that the best method for this was either to do a relaxing incision on the vena cava or to use the vena cava to buttress my repair. And so I went through that phase for a while and realized pretty quickly that it wasn't working quite as well as I thought it would. So we abandoned that technique, but the thing that remained the same throughout my career and the Achilles heel of really any of anti-reflux surgery, as I've said 100 times, is recurrence of the hiatal hernia. That struggle is real, because even in the best of hands, the recurrence rates are somewhere around 30%. And that's with patients with small hernias and reflux. Here's 2 such studies that have looked at long-term outcomes just with regular anti-reflux surgery, not big hiatal hernias. And again, what they found was that recurrence rates were somewhere around 30%. And I will tell you that the dogma that I was taught, and the dogma that continues to be perpetuated here and everywhere I go, is that somehow the Nissen fundoplication spontaneously unwraps, reattaches itself to the spleen, and you're back to where you started. Well, that's not entirely true. If you look at the data of studies that have looked at what is the etiology of the recurrent GERD, it always comes down to the etiology is recurrence of the hiatal hernia. This study nicely pointed out that 85% of the time, the reason that patient got reflux back was because the hernia came back. The Nissen was fine. The Nissen was intact. And I would argue that most of our LES repairs don't fail. What fails is the hiatal hernia repair. This is crural failure. And so, if you've been following along for these last 3 days, if failure is due to crural failure, what should the treatment be? The treatment should be to redo the Nissen? No. The Nissen doesn't fail. It's the hernia that fails. This is a study out of the Cornell group. Phil and others used EndoFlip to determine what was failing and how could I make the barrier back to normal. So they took a whole bunch of patients that had had recurrent GERD after anti-reflux surgery, took them to the OR, did EndoFlip on them, and what they found was that the majority of the benefit of me going in there to refix things was from me fixing the crura. They didn't necessarily have to redo the fundoplication, because again, the LES repairs are durable. Now, our recurrence rate is even higher, as Reg pointed out, in the bigger hernias, the paraesophageal hernias. So what are we doing wrong? Well, C. Dan Smith and others looked at that very question. What what are we doing wrong here? What would improve our outcomes? What do we need to focus on? And so they looked at 200 and some odd patients that they had done over the years. And they looked at a whole bunch of different variables. At the end of the day, they found the overall recurrence rate was over 30%. And they looked at everything to predict recurrence, from the amount of mobilization that I did in the hiatus, to whether I did a collis, to how many sutures I was putting in, whether I was putting them anterior, posterior, using mesh, doing a gastropexy. And you want to know what? Not a single one of them predicted recurrence or prevented recurrence. The only thing that predicted recurrence, and the reason we are here, was surgeon volume. People that did less than 10 of these a year, the recurrence rate was nearly double. It was upwards of 50% if you dabbled in this procedure. And so, as I and Stu Speckler know, the first step of any 12-step program is to admit you have a problem, right? We do. We have a problem. But our answer, every conference I go to, our answer is mesh, or in Tripp's case, vena cava. Well, this is a study that just came out just a little less than a year ago, looking at whether or not if I used permanent mesh at the hiatus, which most of us think is a bit taboo, but nevertheless, it was a randomized controlled trial, prospective trial, looking at the use of barred Crurosoft, so a synthetic mesh at the hiatus versus just suture repair alone. And pretty amazing study. They had 11 years of follow-up. And the punchline to the whole story was that the recurrence rate was the same. The recurrence rate was the same at 1 year, at 3 years, and at 13 years. So even permanent mesh didn't seem to solve our problems. The only thing that was different was dysphagia was higher in the patients that got mesh. Well, I know what you're thinking. I would never use that mesh, and I wouldn't use that mesh either. They clearly got the wrong mesh. We just need a better mesh. I love mesh. I love it almost as much as beer. Well, Samit Mittal came out with a publication just a couple of months ago, meta-analysis and systematic review, looking at the different types of meshes versus suture repair. This is really a fantastic study. 34 studies, 6 of which were randomized controlled trials. They looked at over 2,000 patients and compared suture repair to absorbable mesh to permanent mesh. And they were also able to tease out the type of mesh that was used. And what they found was this: there was really no long-term difference. The recurrence rates were the same, whether we used no mesh, permanent mesh, synthetic mesh, didn't matter. The only benefit that it seemed to provide was in that early to mid recurrence. It was lower when you used mesh. They also thought that the permanent mesh maybe decreases recurrence. But again, we can go back to the last slide I showed you on permanent mesh that showed no difference in a prospective randomized controlled trial. So even though mesh may not be their answer, I think there is some hope here. And I think there's a lot of hope because we've learned a lot over the years. We've made some serious progress in our understanding of this disease. I think we understand a lot better where these recurrences are happening. I think we also now recognize that reflux, hiatal hernias, and paraesophageal hernias are a connective tissue disease. We don't tend to talk about it that way, but this is a connective tissue disorder. And I think we've also recognized that this is a progressive disease. Part of the reason our recurrence rates are so high is because when we as surgeons go in there to fix it, we don't stop the systemic disease. That disease is still there, and that disease progresses. And over time, small hernias become big hernias, which then become paraesophageal hernias. And so ultimately, I think it's this understanding that is improving our outcomes and decreasing our recurrence rates. So first, starting with location. Location is everything, right? Location, location, location. Well, I think we have been focused, or almost a fetish-like attitude towards the posterior crural repair. That's where we all assume the recurrences are, and that's where we put our mesh, right? We close the crura with sutures, and then we put a piece of mesh on there because we're worried about those sutures pulling through. Well, they don't pull through. The recurrences don't happen posteriorly. There's been a number of really good publications looking at that very question. Where is the Achilles heel of the hiatus? Where are things going wrong? And where they're going wrong is on that anterior patient left side. Vic Delanovich published his results and found that 72% of the time it was on that anterior left side. This publication also similarly looked at it and found that the recurrences, 80% of the time, are happening on that anterior left portion. And I think the other thing that we've recognized, and I think largely due to links, was that we were closing the hiatus too loosely. We were panicked about creating dysphagia. And by closing the hiatus a little bit more snug, maybe we'll prevent that early recurrence, which obviously is going to progress over time. And the other thing I think that Reg will point out is that we've been using our mesh wrong. Again, we're putting the mesh posteriorly because of that fear of the sutures pulling out, but that's not what's happening. It's that anterior portion that's stretching out, and maybe if we put that mesh anterior, we would see a difference. And so I don't have all the answers on how we fix the underlying systemic disease, but I have some thoughts. And the trendy thing in medicine right now seems to be using platelet-rich plasma. Platelet-rich plasma is being used for everything. I mean, you name it, it's all the rage. I had tennis elbow, went to the ortho. They took my blood, spun it down, and injected platelet-rich plasma into my elbow, and now I can play tennis. It's amazing. I was getting a little wrinkles because I'm old.
John?
Yes, ma'am?
Tennis before?
Huh?
Could you play tennis before?
No, I could not. But now I can, all because of platelet-rich plasma. It's a miracle drug. Yeah, wrinkles. You can go for vampire facial. Yeah, I think it was Phil and I that just went. Works wonders. That's why I look so young today. Hair. I still got all my hair. How do you think that happened? And it's even being used for other areas which I know nothing about. Let's be clear. And so platelet-rich plasma at the hiatus is an interesting idea. The idea here is to improve wound healing, right? To improve wound healing of the hiatus because there is a structural defect, a connective tissue defect there. And so we really need something that's going to increase collagen. That's been what's found to be defective in patients with hiatal hernias and reflux. They are deficient in type 1 and type 3 collagen. So this was an animal study that was done looking at a hiatal hernia model in a pig. And what they did is they went in there and fixed the hernias. They did a suture repair or they put some biologic mesh along with some platelet-rich plasma. They then had a big old pig roast at about 8 weeks and looked at the pullout strength of that hiatal tissue. And what they found was that the pullout strength was significantly higher in the pigs that had platelet-rich plasma. They also found that it increased collagen deposition, it increased neovascularization, and it increased gene expressions of a whole bunch of things that sound important in wound healing.
Pardon me, John.
Yeah.
I just have to interrupt. So the control, so the control was just suture repair. It wasn't a biologic mesh.
Right.
Okay. So we don't know in a sense whether it's due to the biologic mesh or the
No.
therapy if we're being...
Not in this study, no. Good question.
Show us others.
I'll show you more, a little more. So again, this appears to be a connective tissue disorder, and maybe platelet-rich plasma can help us overcome that. This study right here was done by the Ukrainian surgeons who did the first human trial using platelet-rich plasma in a hernia, in an actual patient, human. Phase 1 of it, they first wanted to confirm that we were right, that this problem is a deficiency in collagen. And so they looked at 18 patients with hiatal hernias and compared it to cadavers that had no hiatal hernias and looked at the collagen content. And what they found was indeed patients with the hiatal hernias had a deficiency in type 1 and type 3 collagen. They then took this concept further and started to do it in humans. Now, they didn't have a control group, so we don't know about that, but they took 54 patients, fixed their hernias, put some pro-grip mesh on there, coated with platelet-rich plasma. And what they found at 4 years after the operation, so 4 years later, recurrence rate was only 3%. I mean, that is much lower than anything else out there in the literature at 4 years. So seemingly very promising. So that led our group down the pathway of doing a randomized controlled trial. So this is the first randomized controlled trial. The video there is illustrating fixing the hiatal hernia, and later on in the video you'll see us come in with a giant needle. We have already drawn the patient's blood. We've spun it down to get the platelet-rich plasma, and then we will inject it into the crura, and we will then place a piece of absorbable vicryl mesh over the hiatus that's been soaked in calcium chloride to activate the PRP, and we will sort of paint it on that mesh. It is a registered clinical trial. Patients have to have a hernia bigger than 5 centimeters to be enrolled. We do a partial fundoplication at the time, and power calculations put the total number of patients that we needed in this trial at about 150. We're not fully enrolled, so I can't show you really all the results yet, but at least initially, it seems like it's working. The recurrence rates seem to be lower in the arm with the patients getting platelet-rich plasma. So stay tuned. We're close to having it fully enrolled. Hopefully next year I will be able to report the final results to see if it makes any difference. Now, the last thought I have was already talked about. I don't know how many of you were at the abstract session, which was the most incredible abstract session AFS has ever had. Some of that stuff was absolutely amazing, and they talked to you about using a vascularized piece of mesh. If you weren't there, what it's called is Portia, using the posterior rectus sheath as your mesh. Very cool idea. So what they're doing here, if you weren't at that abstract, is they take the posterior rectus sheath on the patient's right side, they rotate it down with its blood supply, which is the falciform ligament, and they use that to patch the hiatus. Super cool idea. Whether it works or not, time will tell. They presented some of the data in their abstract. Their paper was published just recently, showing no radiologic recurrences. Follow-up is short, 11 months, but to me, seems like a very cool idea. They had one patient with dysphagia, and then as far as extra time, it was about an hour initially, but they became faster as they did more, adding about 15 to 20 minutes to the procedure. So I will summarize everything very quickly so Reg can ask me questions. First and foremost, remember, Coors is a great beer. Secondly, remember that the barrier is both the crura and the lower esophageal sphincter. We need to stop talking about the lower esophageal sphincter and start talking about the crura. Failure of anti-reflux surgery is failure of the hernia repair. This is a progressive disease. It's an underlying connective tissue disease. We need to focus on that, as well as figuring out a way to prevent those anterior and left-sided recurrences. Our LES repairs are good. I don't know why we keep trying to make better LES repairs. We got a ton of them. Let's stop focusing on the LES. Let's focus on the crura. And so at the end of the day, I think my final thoughts are, I think our better techniques and understanding of this disease are helping us, and it does seem to be lowering our recurrence rate with anti-reflux surgery and paraesophageal hernia repairs. So with that being said, Reg, fire away.
John, excellent presentation, and John and I have talked back and forth about mesh. But I think you brought up a couple of really good points in this. First off, we focused on thinking of it as a recurrence as opposed to progression of disease. Hernias don't develop posteriorly, they develop anteriorly, and we have not addressed that anterior portion. Really, none of the mesh studies address it properly. So to me, I think we're starting to rethink this whole thing. Mesh makes a difference in every other hernia repair we've done, but we haven't shown it makes a difference here, and it raises the question, what are we screwing up? What are we screwing up? Because it ought to make a difference, and I think you've addressed that very well. It hasn't been in the right place. And it may be mesh, it may be PRP, but we have to do something to address where the hernia develops. It's not a failure of our sutures necessarily, it's a failure of us recognizing where the progression of the disease is going to be. And I think we're sort of turning things topsy-turvy like you've done really well with reconstructing the LES or the hiatus from a physiologic anti-reflux barrier point of view. So I really think that's great. The next thing is, when we do this, we disrupt a already beat up phrenoesophageal membrane. So it strikes me that the next step in all this is going to be to find a way to reconstruct in some fashion or revamp or do something that imitates a phrenoesophageal membrane. So just to close out, I think you probably have some thoughts on that, but that's got to be kind of our next step after we figure out this other problem. So tell me your thoughts on that, and then we're going to break.
Well, I think the easiest way to answer that is I will take it even a step further. I think even just the development of a first-time hiatal hernia, the weak area of the hiatus isn't posterior. It's that anterior left side that stretches out. That's our Achilles heel in this disease. And we need to figure out a way to fix that and reconstruct that phrenoesophageal ligament. That's why when I stumbled across that Portia study, that seems like it has the potential to do that, because that's your own body's tissue. That's the connective tissue we don't have at the hiatus, and we don't have fascia, we don't have anything at the hiatus. So time will tell with that, but I think that is a really cool concept that could work. The idea of platelet-rich plasma, maybe, if that can truly overcome that connective tissue genetic component of this disease, but time will tell.
Perfect. Now this is a trivia question for the audience. John, I think, knows the answer. But early on in the days of hiatal hernia surgery, there was a surgeon whose name you know, who closed the hiatus anteriorly. And at 4 years, he had 84+% success rate. So who was that surgeon? Anyone know? It was not Allison. So, sometimes it helps to go back and read the old literature. It was this guy, John Collis. Yeah, he closed it. Because he was a thoracic surgeon, it was easy to close the anterior.
Comment on that, Red, just real quick. In the old days, anybody over a 5-centimeter hernia, Tom DeMeester said we had to do it transthoracically. And so we did every patient with a bigger hernia transthoracically. And the recurrence rates of the hernias were indeed less than what we see laparoscopic. Now, if Steve DeMeester was here, he would say it's because we mobilize that esophagus all the way up to the aortic arch. But the other thing that was different about a transthoracic repair, for us, at least at SC, was we had anterior stitches on everybody. And we don't tend to do that laparoscopic very often.
Well, great discussion. I think we as surgeons have our work cut out for us. So